RetinaRounds, episode number 240. Today's case, submitted by Dr. Sima Sheikhghomi, a retina fellow at Farabi Eye Hospital in Tehran, Iran, explores persistent submacular fluid after scleral buccal repair performed without subretinal fluid drainage. With the macula still detached, how long should we observe and when should we consider intervention? Dr. Rahimy and I discuss OCT findings, visual implications, and a practical approach to management. Thank you, Dr. Sheikhghomi, for sharing this case. Okay, welcome back to Retina Rounds. Ehsan, we've got a case today from Dr. Sima Sheikhghomi. She is a retina fellow from the Farabi Eye Institute in Iran. And so she's got a case where she's done a scleral buccal. This is the 39-year-old patient who has about a 1-month history of decreased vision in the left eye. Vision is 2200 at presentation. And this patient's got a number of small atrophic holes in the infratemporal periphery. The macula is detached. And so her plan is to do a scleral buccal. This patient does not have a PVD and is phakic. So I think a good choice to do a buccal in this scenario. So let's go ahead and take a look at the case together. And what you'll notice at the end is that there is some persistent subretinal fluid in the macula. At her institution, they actually don't routinely drain subretinal fluid due to the concern for hemorrhage and tracking into the macula. And also, they don't do cryotherapy. At the time of scleral buckling, they perform laser retinopexy in the postoperative period.
What's your go-to, buckle element for a case like this with peripheral just atrophic breaks?
In a case like this, let's just say it's just infratemporal atrophic holes. I like to put a 276 element in that quadrant, a broader element, and an encircling 240 band. And that works really well in my hands. Some surgeons like to use a broader element, like an S40-50 band, which I think is harder to come by nowadays. But it gives you a broader support with the sort of the ease of putting on a typical encircling band like a 41 or a 42 band. How about you? What do you have a preference when you have a quadrant of pathology? Do you still like to use an encircling band and just use that to cover the breaks, or do you like to use a wider element in that quadrant?
Yeah, I mean, assuming they likely have pathology elsewhere, lattice and whatnot, I still like to do something encircling. I'll either go for like a 41 or 42 band sometimes in some cases just to get a little bit of extra imbrication. And what I like to do if you have again a specific region with this pathology, assuming it's not too posterior, it sounds like we don't have that with atrophic holes here. I like to secure the sleeve in that respective quadrant, and I might even do a little bit of a wider bite with her sutures, and you get this nice little extra support, if you will. And I find that oftentimes I can get that same amount of, broad support that I'm seeking, or that you mentioned with what you use. But it's nice to hear what different doctors do. The key thing is just find whatever works best in your hands that you do repeatedly and you're comfortable with, and you can get the same outcomes.
Yep. All right. Well, let's take a look at this case.
Interesting. They don't dilate the eye.
That's right. No dilation here. Starting with doing the conjunctival peritomy.
So you
Um,
truly are just putting the buckle on and closing and getting out, basically.
That's exactly right. This
Very
this
interesting.
case I think is was submitted maybe slightly sped up, but the whole case is maybe about 20-30 minutes.
Yeah, I guess if that's your objective, you're just probably in and out then.
Yep.
Maybe not the worst thing in the world. Like, it's an interesting approach to this.
I like the peritomy that they've left a little bit of a skirt.
Yeah.
It helps to preserve some of the goblet cells, maybe decrease the risk for dry eye syndrome later on, and also is a nice anchor point for conjunctival closure at the end.
Yeah, I agree. I do the same thing.
I like to do a little bit of a radial relaxing incision at three. Typically, I'll do it at 3 and 9, just
Mhm.
because inevitably the conjunctiva will tear with all the manipulation, and it's nice to have clean edges that you can reoppose at the end of the case.
I agree. And sometimes what we'll do actually at the beginning of the case is just mark with a marking pen at your 3 and 9 position so that it helps opposing that properly when you're closing at the end.
Yeah, great idea. So you can see here she's isolating the rectus muscles using a non-loaded muscle hook here to isolate the muscle, then using a cotton tip applicator to strip back the surrounding tenons, and then placing a fenestrated muscle hook behind that, then loading the silk tie and then pulling that through. In my own hands, I just start with the fenestrated hook with the silk tie and I just pass
Same,
it.
yeah, same
It's
here.
uncommon to have to actually split the muscles, but if you do identify a split muscle, you can always just repass it with another fenestrated hook and a 2 silk.
Yeah, I agree. Although for me, it's interesting. What's your order of preference? I always go medial, lateral. Then that gives me good kind of like, I can do good vertical displacement to then go after the inferior and superior rectuses. What do you do?
I always follow the spiral of Toulouse, so I'll start medial, inferior, lateral, and then use the medial and lateral as you just mentioned to infraduct the eye. Now you can see she's isolating the superior rectus. This is the most critical part here, is just to make sure you don't get the oblique. And so I do this very technique actually is I'll place a non-fenestrated muscle hook to isolate the superior rectus, and then I'll place that fenestrated hook with a toe silk tie in front of that non-fenestrated hook. So I'm kind of drawing, if I have engaged the superior oblique, I'm kind of pulling those fibers away from the rectus, the superior rectus muscle insertion, just as an extra layer of protection to make sure that I'm just getting the rectus and not engaging the oblique.
Two comments here, and I'm curious, what do you advise people? Because I've seen it and said it both ways. Like you're supposed to go from nasal to temporal or temporal to nasal when you're passing that muscle hook to avoid the oblique. What do you usually teach? What do you do?
Honestly, I don't know that it makes all that much of a difference.
I've seen people say both ways, and I think you made my point, which is going to be like I think it's just have good visualization, like watch your visualization and pay attention. The other point I was going to make is there's so much emphasis on not incarcerating the superior oblique that people or trainees sometimes forget there's another oblique muscle too. And I have actually seen more cases of inferior oblique incarceration from just doing deep sweeps and grabs when you're trying to capture that lateral rectus. That's where you're going to run into trouble. Just be very careful doing that.
Yeah, that's a great point. And yeah, it's something that we really don't talk about enough, but absolutely. I've been in that situation where I've done too deep of a sweep and I've engaged the inferior oblique. So you definitely have to be aware of that.
So what suture material are they using here?
No, I can't quite tell. Looks like it might be Merceline suture, but
Yeah.
that's usually what I'll use. Some people like a sort of monofilament nylon suture. It doesn't really matter. Both work just fine.
Looks like a pretty wide pass here. What are they going to put here?
That's right. So she goes on to place these pre-placed sutures in each of the quadrants,
Hmm.
and now you're going to see this the element that's going to be introduced here. So here it is. You can see that there's the this looks like a 276 tire that's going to be placed with a 240 band, 360 degrees. They're very, it's a wide element. It's about 7 millimeters wide. Um, so definitely going to cover whatever pathology is there. You know, I usually don't place this wide of an element 360 only because you can sometimes get compression of the vortex veins and you can get
I was worried about anterior
weird.
segment ischemia syndrome or something like that with
Yep.
this bulky.
That's a concern as well. And so I'll usually just use a 276 tire in maybe two quadrants at most. I do have some colleagues who actually do this 360 and they don't have any issues. But I actually did one case where I did three quadrants and I saw some overlying effusions. They settled down over time, but I just prefer not to have something as big as this all the way circumferentially in the eye.
Do you pre-place sutures too?
I do. I
Yeah.
do. For the tire, I do. Just an encircling band like a 41 or 42, I'll just put the band in place and then just put the sutures around the band.
Hmm.
But it's just too hard because of how wide the element is, I think, to place the sutures after the element is already in place.
Yeah. Do you
Another
do
thing
buckles under the scope?
I have been doing so more so now with presbyopia setting in.
Yeah.
Um, but one other thing to keep in mind here is just to keep your sutures ordered, sort of nice and tidy. Use bulldog clamps. One of my mentors, Dr. Alan Krieger, Buzz Krieger, used to use just a paper clip. Actually, basically all it was to organize the sutures so they wouldn't get tangled. Just something important to do because if you do get them tangled and you tie off your sutures, then you have to replace it if they become tangled.
Hmm.
So I like the way that they're tying off these sutures. You see, the assistant is kind of pushing in on the buckle to get so that the suture tension can be appropriately taut, and then holding the knot in place until the second throw can be tied to secure the knot in place, and then a third. One thing that I'm not seeing though on these on this video is rotation of the knots posteriorly. And this does look fairly posterior, so maybe erosion is not as much of a concern, but I always rotate my knots posteriorly just to avoid any erosion of the overlying conjunctiva.
Same.
All right, so it's looking like the sleeve is being placed in the supranasal quadrant, and then the conjunctiva is reopposed, looking very good, and that's it. So no cryo, no drainage, just placing the buckle and then waiting really for that fluid to settle down so that the brakes are opposed to on the buccal surface, and then applying some laser in the postoperative period.
Nicely done.
Yeah, I thought the on sort of just the technicality and the technical skill of the surgery, I thought it was really well done. Very similar to how I do the case. Some minor differences, but overall it was really a well executed buckle. So let's take a look at the postoperative outcome.
And some subretinal bands.
Exactly right. Yeah. So here's we don't have any pre-op pictures, but you can see here the post-operative fundus photos. This is of the macula. I'll show you an OCT in a little bit that'll show that there's still some subretinal fluid in the macula. You can see these subretinal bands, one that's in the macula, and then this other picture that's showing a little bit more of a peripheral infratemporal view. You can see there's a little bit more of a mid-peripheral subretinal band.
Above it. I think that shows the buccal imbrication nicely.
And in this supratemporal quadrant, you can see the buccal
Very
imbrication
good.
there as well, and looks like maybe some photocoagulation spots that were applied here. And in this last photo, you can see at the very bottom of the image some of the photocoagulation that was done around those atrophic holes that were identified preoperatively. So here's the OCT.
Hmm.
You can see that the fovea is detached. Um, and in this scenario, the brakes are supported by the buckle. You've got retinopexy to secure the retina in place. The patient's vision at this point has actually improved from 2200 to 2060 despite that persistent subretinal fluid.
Great.
So the question is what are you going to do at this point? Are you going to do anything? Just watch? Are you going to add on some maybe a adjuvant to help accelerate the resorption of the fluid? What's your preference?
Case by case basis. I mean, and clearly in this case, with a patient who's subjectively and more importantly, objectively already improved, we already have a W. You know, we're not going to like snatch defeat from the jaws of victory here. I would probably err on doing less here. But options in these cases, and we were talking about this before we recorded, we have a few of these. I get a few of these every year. It's just more about a discussion with the patient. Sometimes you can consider doing an in-office pneumatic, like putting a bubble in the eye and seeing if any face-down positioning helps kind of like displace it temporarily. In my experience, and this looks like it, when it's chronic viscous fluid like that, all these kind of interventions aren't going to do anything. It's just a matter of the fluid needs to resorb on its own over time. Um, I've put patients with this sometimes on courses of Diamox, provided they tolerate it, they don't have allergies, their PCP's okay with it. The fluid eventually goes away. I don't know if the Diamox helped or not. Maybe it was going to go away on its own. But in those cases, it feels like for my sake, for the patient's sake, it gives us something to do and something to monitor. And I'm sure you're going to say the same thing. This fluid typically will go away over time. I wouldn't be going back to the OR to do any kind of drainage because, again, and if you're just thinking about the time of the initial surgery, even if you drained, you're not going to get that fluid out. That fluid is like chronic viscous loculated fluid in the macula. It doesn't matter if you drain it or not, you're not getting that fluid out. It's just a matter of maybe if you had put a bubble in, is that going to help displace it or not? And again, in my experience, it doesn't. So it's just a matter of time.
Yeah, I agree with everything you said. Especially in younger patients with very liquid, very sort of still formed vitreous. Their liquefied vitreous is thicker. It's like almost like syrup if you do try to drain it. And you're right, you can drain it to really the purpose of the drainage is to get apposition of the break on the buccal. And if you don't feel like you're going to be able to adequately do that, that's the scenario where I decide that I'm going to drain personally. No, in this case. It sounds like at this institution, they don't drain routinely at all. Now, if I have a patient where I have drained, or maybe I decided not to, but I'm not seeing good apposition in the postoperative period, in that scenario, I might put a bubble in and have them positioned to kind of push the the retinal break into position. But if the break is supported by the buccal, that's really all you need. Everything else will follow from there. The fluid, as you said, will naturally pump out. The RPE will naturally pump that fluid out. And depending on the age and the viscosity of that fluid, it can take, a week. It could take many, many months, but it will get better. And I think that using serial OCTs, serial fundus photography can really help get a very objective determination of whether things are moving in the correct direction. And if they are, I would just kind of let it roll and see what happens. And if it's not, and the brake is closed and there's no other reason for the fluid to not be going away and you want to try to accelerate it, I think using Diamox in that scenario is a really good idea. I haven't personally tried using a bubble to displace subfoveal fluid, but um, I think that with time things will improve. And there are a number of studies actually that have looked at this question of like, does it matter whether there's subretinal fluid or not? There have been some seminal papers looking at buccal versus vitrectomy outcomes. Vitrectomies, obviously, oftentimes they're fluid free in the early postoperative period, whereas buccals take a little bit longer. And it turns out that some of those studies have not shown a significant a difference in visual outcome. There was an interesting paper actually that was published in Nature Scientific Reports. I'll show um, the citation here. What they found was that if you look at this graph here, you'll see that the amount of time that it takes for that fluid to go away, that persistent subretinal fluid to go away, is shorter in patients who had a drainage procedure done versus those who weren't drained. Um, and if you look at the visual outcomes, you can see it in at literally every time point in the postoperative period, the vision in the patient that underwent subretinal fluid drainage was better, including the final visit, was better than patients who had not undergone subretinal fluid drainage.
Is
Um,
this all comers or there's chronic detachments? And if so, like what was the time duration of the detachment? Did they say in the
I
study?
don't know, and I don't know the age of the patients. But I will say that the decision to perform drainage had to do with whether or not the surgeons felt like they could adequately oppose the brakes on the buccal. So if they could without drainage, they would just do that, no drainage. If they didn't feel like they could, then they drained subretinal fluid so that the brake would fall on the buccal contour. So, look, I think there's a lot of papers that indicate that drainage, persistent subretinal fluid may not make a difference. In this particular study, I thought it was interesting just to point out that there may be some evidence that it does make a difference. In both scenarios, the vision improves. It's just a matter of how much the vision improves. And retinal detachment outcomes are hard to study because there's such heterogeneity in the patients. It's hard to know whether or not this is real. There were about 60, a little over 60 patients in this study. But it does raise the possibility that actually getting rid of that fluid earlier, that submacular fluid earlier, may result in better visual outcomes. So just something to keep in mind.
I like something you said kind of as my North Star is draining going to help oppose that break over the buckle? That is our goal of surgery. If I don't need to drain to do that, I still err on not doing it. The last thing you want to do is, as we all know, get hemorrhage, especially if these are MAC off detachment eyes, and that fluid, that blood is going to quickly track into the macula, and now we're stuck in a suboptimal situation. And if I feel like then what we have is not adequate to support that break, that's where we'll drain. So that's kind of my decision tree.
Yep, I completely agree with you. And not only hemorrhage, but also if, you can get a retinal perforation, you can get retinal incarceration. There's all sorts of potential risks with external subretinal fluid drainage, and it's a decision that shouldn't be made lightly. You have to weigh the pros and the cons.
No free lunch either way.
Yep. Well, we want to thank Dr. Sheikhghomi for sharing this case with us. Outstanding surgical job, and I'm sure this patient will that fluid will eventually go away, and this patient will have a very nice visual outcome, even beyond what they've already been able to achieve. So thanks for sharing it, and we'll see you again next time.
Thanks for sharing that great case.
If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.